This is the third lecture on fluids and electrolytes. This lecture really focuses on the roles of calcium and magnesium. We are first, though, going to begin talking about a couple of hormones, and these hormones affect not only calcium and magnesium, but also phosphorus, and phosphorus will be talked about on the next lecture. So let's do a little review here. PTH, or parathyroid hormone, is the only hormone produced by the parathyroid glands. It's the primary regulator of blood calcium levels in the body. It has a number of functions, but in terms of blood calcium levels, hopefully from A&P2 you recall this. This is your primary regulator. The parathyroid hormone targets the osteoclasts of the bone to stimulate their function and therefore remember, osteoclasts break down bone, so their function then is to release calcium from the bone. This is where we store the majority of the calcium in our body. Recall that intra and extracellularly we have very, very little free calcium, almost none inside the cell. It's all, if it isn't in a cell, it's in a sarcoplasmic reticulum, but it's not free floating within the cytoplasm at any significant levels. And outside the cell, it's also very low. So we are monitoring those levels very carefully, and PTH is the main hormone that does that. Now, calcitonin, not calcitriol or calcitriol, how you pronounce it, is not the same as calcitonin. You may recall from A&P2, calcitonin was made by the parafollicular or C cells of the thyroid gland, and they have the opposite effect of PTH. However, PTH is our primary regulator and the one we focus on most significantly. So it is released when serum calcium levels drop low. It increases in serum phosphorus levels, will also increase PTH secretion. So we're going to look at the phosphorus and then also see how magnesium figures in here as well. So what is its functions? It stimulates the release of calcium and phosphorus both from the bone. So in other words, both calcium and phosphorus levels will rise as PTH levels rise. It also increases renal absorption of calcium, so it saves calcium at the kidneys, at the tubules, making sure really at the very end of the distal convoluted tubule getting towards the collecting duct, that's where it actually targets, the PTH targets, and it helps maintain or retain calcium levels. You'll reabsorb those. Notice though that phosphorus is actually excreted at the kidneys. So PTH helps release it from the bone, so we increase it that way, but PTH also helps get rid of it at the kidneys. So it really monitors PTH very carefully. Calcium we're just retaining. And notice also in the third bullet point here under functions, it enhances GI absorption of calcium and phosphorus through its role with vitamin D, which we'll talk about in just a second. But that's an important factor. So PTH allows us to release it from the bone, release both calcium and phosphorus from the bone, absorb both in the GI tract, so along with vitamin D's help, that will happen. But at the kidneys, they have opposite effects, and so that sometimes gets a little confusing. But we are monitoring phosphorus very carefully because phosphorus really can compete in certain areas for calcium and can affect their function. So they tend to have, in some sense, they have some opposite levels and effects. As phosphorus goes up, calcium level tends to go down, and vice versa. So because they compete with each other, they'll bind together, and then you no longer have free calcium. We'll get into that a little bit more later, but noticing this difference in the role of PTH. Calcitriol, or the active form of vitamin D, has several effects both on the intestines, the kidneys, and the bone that will increase the levels of calcium and phosphorus. Now, calcium's a bigger deal than the phosphorus, but they will both be increased in their absorption. And so it is the vitamin D that allows us to help maintain phosphorus levels, so that promotes reabsorption. And actually there is a negative feedback on PTH levels, so as the vitamin D starts increasing and therefore we start absorbing and keeping more calcium, we don't want to get to hypercalcemia, so calcitriol actually has that negative feedback on the PTH levels as well. Now, as calcium levels rise, it will also have that negative feedback, but the calcitriol or vitamin D is another factor in regulating that control. So let's talk just a little bit about calcium. It gets a little tricky with calcium because we have a lot of calcium in the body. It's often bound to something. And so when it's bound to something, not ionized, we can't look at that as having the same functions in the body. We are concerned about electrolytes. We're not concerned about, not in this chapter at least, let me say, we're not concerned about calcium in terms of how much of it there actually is in the bone or how much of it is bound in these various areas. When we start talking about issues of calcium levels, we're talking about the ionized calcium. So it's important first and foremost to understand that calcium does exist, though, in multiple ways. So in the blood, it's bound to albumin. Albumin is that plasma protein that's made by the liver. Remember, back at the beginning of this chapter, we talked about maintaining blood colloid osmotic pressure or capillary osmotic pressure. Well, that osmotic pressure is maintained by that plasma protein albumin. Well, within the blood, you will find that calcium will bind to it. Because calcium is bound to it, it is not an ion. So this is going to be an important factor, and you see the two smaller bullet points here below with regards to its effect on pH. This is an important factor to know, and it does change. The binding can change with changes in pH. But when it is bound, that calcium bound is not what we're looking at in terms of ionized. Now, it can figure into total calcium in the body when you draw the blood and test for total calcium. This will be counted in it, as will any calcium that's bound to citrate, phosphorus, or sulfate, other things in which calcium can bind to. They figure into total calcium, but not the ionized calcium. Ionized is the third way in which you find calcium in the extracellular fluid. Found in the blood, bound to albumin, bound to citrate, phosphorus, sulfate. And there are actually other substances calcium will bind to, but those are the big ones. Or it is ionized, and the ionized is the part we're going to be looking at in a moment. But let me jump back up here to what I said about the pH. So when pH levels rise, and when pH rises, we're going into a more alkalotic state. There's actually less hydrogen available. In alkalosis, you find that there is an increased binding of albumin and calcium. So in alkalosis, you wind up having hypocalcemia. So get this in your mind, because remember, by the time you take this exam, you're going to have all of the fluid stuff, all of the electrolytes, and all the acid base, and you're going to have to pull this information together. So you come across a patient that has alkalosis, you're going to be thinking to yourself, well, that may also mean hypocalcemia. Got to take a look at where is their calcium at, because there'll be increased binding of albumin and calcium. Likewise, if you're in an acidotic state and your pH is starting to drop, and when your pH drops, there's an increase in the hydrogen ion concentration. Increases in hydrogen ion concentration, lower pH, acidotic state, and that decreases binding. All those extra hydrogens actually break the bonds between calcium and albumin, and you wind up increasing your free calcium, and you have hypercalcemia. So please try and get that kind of cemented in your mind as we go forward with the subsequent lectures on acid-base balance. We need to keep that piece in mind, because all the effects that occur with hypo and hypercalcemia in those various conditions will also play a role when we start to talk about types of alkalosis or types of acidosis. Now, the actual functions of ionized calcium are listed here for you. They're pretty self-explanatory. I'm not going to read them all through, just recognizing if you need them for enzyme reactions, if you have too much, those enzymes are going to get used up. We talked about that with impaired calcium homeostasis back in chapter 2. So we're really just reinforcing some of what we've already done with calcium already. It stabilizes membranes by controlling the amount of sodium that can enter the cell. So when I talk about stabilizing membranes, I'm talking about excitable cells. Needed for neurotransmitters, hormone release, and of course it's involved in blood clotting. So how do we regulate it? We've already mentioned that with PTH and calcitriol. So the primary regulator is really going to be at the kidneys. I mentioned calcitonin. It's listed down here. Released from the parafollicular, or sometimes you may have learned them as the C cells of the thyroid. Also target, that's poor spelling, I apologize for, but it targets osteoclast and has a minor effect on calcium levels, opposite of PTH. If we remove calcitonin from the body, PTH and calcitriol can do the job really very well by themselves. And as long as they're functioning normally, lack of calcitonin in the body would really have minimal to no effects. The body would return back to homeostasis very quickly within days. If, say, that the thyroid gland were removed, parathyroid remained, you wouldn't necessarily have to be supplementing calcitonin. Now you've got to supplement T3 and T4. That's a whole nother. We're not there. We've already done that one. All right, so hypocalcemia, some causes for hypocalcemia. Renal failure is a big one. And notice that hypocalcemia is often paired with hyperphosphatemia. If the kidneys are failing to retain calcium, they're probably also failing to excrete phosphorus. They're not doing the jobs it's supposed to do. I mean, you see that many issues of electrolyte problems are linked to kidney problems. If there's some problem with obtaining calcium from the bones, you've lost your functions of the parathyroid hormone, tumors have formed there. Pancreatitis is a common cause for hypocalcemia. Lipases are enzymes produced by the pancreas to help break down lipids within the body. That's what they do. So an increase in lipases breaks down fats and prevents formation of vitamin D. Vitamin D is lipid based, so then calcium absorption and reabsorption is diminished. So this pancreatitis means whatever we take in, we're not absorbing. So there's a problem there. Increased protein binding due to acid-base disorder. That's what we just mentioned before. And administering stored whole blood goes back to those blood clotting factors, and the calcium can bind to whole blood. Can bind to whole blood as it's been administered in the body, because there's usually citrate in there, and so it's binding to that citrate, causing hypocalcemia. Now, the manifestations for hypocalcemia, I reference you to the table in your book. Table 8.6 covers those various manifestations. Some of the biggest problems are going to be on muscle neural effects and also cardiovascular effects. If you remember, in the cardiac action potential, calcium is your ion for contraction. So the strength of contraction of cardiac muscle, all muscle, but particularly cardiac muscle, it can be profoundly affected. And so you will see cardiac insufficiencies, inability for the heart to pump effectively because it cannot fully contract. There are ECG or EKG effects on that as well. They're listed in the table. Prolongation of the QT interval is one of the biggest indicators of problems with low calcium levels. But I have two, as I've mentioned with the other electrolytes we've already covered with sodium and potassium. The big focus is not so much on those manifestations, but recognizing those functions. Back up a slide, or 2 slides, to what exactly is calcium doing for us in the body. What happens if these things are not, if they're not happening for us. But I have 2 specific signs. They're really more tests than they are specific manifestations. The manifestations are linked to muscle contractions and nerve stability. But these 2 signs are important. They are both shown with pictures in the book. So Schwostek's sign occurs, or is a test that can be done, in which you tap the facial nerve. It's right on the face, just below the temple, and if there's a twitching reaction of the lip, nose, or face, it's a positive Schwostek sign. So that's an indicator of hypocalcemia. That tapping of the nerve and that inability for the muscle to contract effectively and the nerves to function correctly gives a twitching or an abnormal stimulation going on there. Trousseau's sign is similar to some extent, except we're not dealing with the face. Then what we do is we place a blood pressure cuff the same way you always would on the arm over the brachial artery. You inflate it to about 10 millimeters of mercury above what you know to be the systolic pressure, and you leave it on there for about 3 minutes. And if tetany forms, the muscle, because you need the calcium also to break the bridge, and remember the neurotransmitters aren't being released appropriately. If the fingers and hands kind of contract in sort of an awkward downward position, and I encourage you to look at the picture in the book to see this effectively. If they lock in place and the person can't relax those muscles, that's Trousseau sign. So Schwostek's and Trousseau sign are indicative of hypocalcemia. You'll see they are also related to hypomagnesemia and hyperphosphatemia, so just the opposite. So these signs indicate some problems with calcium, magnesium, and phosphate. Calcium is the big one, but you will also see them show up with those other two electrolytes. Okay, with hypercalcemia, this one tends to be more of a lifestyle or a disease process per se. In other words, hyperparathyroidism is usually something that's happening if there's a tumor in the parathyroid gland. That's pretty rare, but there are a lot of cancers that wind up with hypercalcemia, and that's due to the paraneoplastic syndrome. So think back to the cancer lecture, paraneoplastic syndrome, where the cells of the cancer start producing substances they wouldn't normally produce. There are some lung cancers, small cell lung cancer, for instance, that produces a lot of PTH, and actually it's not the small cell, I apologize for that, it's not small cells, the ADH, but there it is I can't remember the name of it. I'm sorry now. It is a different lung cancer that and I'm going to check my own notes to be sure I don't continue mess you guys up. I'm sorry about that. It is squamous cell carcinoma, squamous cell lung cancers that have the paraneoplastic syndrome with PTH. And in that case, those tumor cells start producing parathyroid hormone. The patient has hypercalcemia. Nothing else seems to be going wrong. PTH levels are normal. That's indicative of a lung cancer, and they'll go searching for that malignancy. Elevated vitamin D levels, they're more likely to occur. Misuse of you're taking a lot of Tums, or that's sort of what happens with milk alkali syndrome as well. It's an excessive amount of some sort of laxative or substance that the person is taking in. So it's any kind of excessive ingestion of calcium. And then there are some drugs, lithium, thiazide, or diuretic usage can be a cause. Manifestations, again, I direct you to the table in your book. The focus on those manifestations is still primarily on what are the effects of the heart function and neural excitability. In fact, with the manifestations in the neural excitability are very similar in both. You'll have muscle weakness. You have the paresthesias and hypo, not so much in hyper, but you certainly have loss of muscle tone. What happens is you've exceeded all of the enzyme usage. You wind up depleting ATP because the ATPase has been completely depleted from the excess calcium, and so although you would think you would have increased excitability because you had more activity going on, it's sort of the way potassium works. You have a little bit of increase initially, and then it's depleted, and now you have kind of an inability to have the neurons firing and functioning as you would expect. Other manifestations you do need to recognize. You would see a shortening of the QT interval on your EKG, so that's important as well. And then because you have loss of muscle tone and nerve impulses, you're going to see that GI effects are pretty significant because everything starts slowing down in the GI tract, and there can be constipation, nausea, vomiting there. One other one I didn't on your causes, I'm just looking at my slide here before we move on. Immobilization is a cause. If a patient is bedridden over a long period of time, the bones will start to break down, the osteoclast activity will actually increase, and you will see calcium levels rise significantly. So when you have someone who's bedridden, particularly if, say, the patient's comatose, you have to really monitor calcium levels. All right, magnesium. So this is a huge long list. It's not something you can really well memorize, but magnesium has enormous numbers of functions. The book walks you through them, and so I encourage you to just kind of read through that a little bit. Again, there's lots of things magnesium's doing. We keep learning more and more about its functions. I'd like you to focus on its functions in cardiac muscle cells. As you see, it says there, magnesium will block the outward movement of potassium. So what happens is, think about your action potential. Sodium opens the gates. Calcium then moves. If sodium rushes in, or the gates open rather, sodium rushes in, then calcium is allowed to enter in and be released from the sarcoplasmic reticulum, and then there's contraction, and then potassium is responsible for the repolarization. And so you need potassium then to move out in order to reset for the next, to get back to your resting membrane potential. So in cardiac muscle cells, magnesium blocks that outer movement of potassium. So that can lead to cardiac arrhythmias, abnormal heart rates, because the cells can't reset, the nerve cells can't reset in order to initiate the next action potential. So in all muscle cells, the the ICF, intracellular fluid levels of magnesium, so inside the cell, the magnesium blocks calcium movement into the cell and the calcium release from the sarcoplasmic reticulum. So in cardiac cells in particular, we've got a problem with resetting back to the resting membrane potential. In all muscle cells, this includes the heart. The magnesium will block the calcium in and block the release. So that's a normal function. In other words, we don't let in too much calcium. We don't let too much calcium being released from the sarcoplasmic reticulum. In cardiac cells, it doesn't let too much potassium. So in normal levels, this is a normal function. So that's the part to understand in normal. But if I have too much magnesium, if I go to hypermagnesemia, think about what the effect will be there. We'll talk about that in just a minute, but think about that. If I have too much, then really I can't get the potassium out of the cell to reset. If I have too much, I can't let any calcium be released from the sarcoplasmic reticulum or move into the cell. And if I don't have these things happening, the muscles don't contract. So you actually use magnesium as a muscle relaxer. So think about that. Let's go on briefly with the regulation, then we'll go back to the hypo and hyper. So, how's the electrolyte regulated? Kidneys are the primary regulator. Now, PTH is involved here, but really magnesium is more of a regulator of PTH than in fact the other way around. So the kidneys reabsorb predominantly at the thick ascending loop, as it says right there. So the kidneys really have a mechanism to regulate magnesium independent of hormones. Now, PTH stimulates some reabsorption, so it has a little bit of a role there. It's not huge. Sodium and calcium increases reduce magnesium reabsorption. And aldosterone actually can enhance the secretion of magnesium into the urine. So aldosterone promotes the loss of hydrogen, promotes the loss of potassium, and it actually can have some effect on magnesium. It's a smaller effect, but it does have a role there. And then some diuretics also increase the loss. Now, one thing I would have mentioned when we did the potassium lecture, I think it was the previous Fluids and Electrolytes Part 2, I think, had the potassium in it. Magnesium and potassium are fairly well linked together. And part of that's when that role aldosterone plays with it. So it's important to understand if magnesium levels run low, and it's mentioned here in the next slide, the effects of hypomagnesemia are exaggerated by hypokalemia and hypocalcemia and metabolic acidosis. So if magnesiums are low, low potassium, low calcium, and an acidotic state will make the situation worse. But it's important to understand hypokalemia and hypomagnesemia at the same time, low potassium, low magnesium at the same time. If you only give the patient potassium back, the magnesium will remain low and the potassium will simply drop low again. The body cannot, particularly the kidneys, cannot start keeping any potassium at all if magnesium levels are still low. So they work hand in hand together. So Causes of hypomagnesemia: insufficient intake, losses, laxative abuse, antibiotics, because we've got several things. And again, high aldosterone levels, because aldosterone promotes the loss of magnesium at the kidney. So Cushing syndrome is the disorder that does that. There is some ICF-ECF shifting that takes place. That primarily is occurring, interestingly enough, we've done ICF-ECF shifts with potassium in order to regulate that very closely. This is very short-term effects, but it occurs if there's been a rapid administration of glucose or if we're in an alkalotic state. This may cause some shifting to occur. So if we're in alkalosis, then the shift occurs that can lead to hypomagnesemia. Again, that shifting is always the body's efforts to make a compensation for abnormal levels. The manifestations, they are similar to both hypokalemia and hypocalcemia, and they are in table 8.7 in your book. Effects here, a lot of these really do overlap a lot with the other disorders, so I don't ask a whole lot about these manifestations. But I'm sorry, I was just looking at the book for just a second, making sure I have that table right. And magnesemia is actually table 8.8. I apologize for that, so please make a note. That's table 8.8, not 8.7. 8.7 is the issues with phosphate. So 8.8 is for manifestations of hypo and hypermagnesemia. I apologize for that. But again, the manifestations are very similar. You've got the paresthesias, tachycardia, many of the same things you'll see elsewhere. So focus a lot more on what I've said about causes and these functions. And let me just reiterate again that important effect of magnesium as a muscle relaxer. If I increase magnesium levels, I can't reset, I can't have a next action potential to occur because of the potassium movement, and I don't have calcium released and being moved into the cell at the rate I need, and the heart cannot effectively contract. Now, if I need to take a muscle relaxer, and actually magnesium sulfate used to be given, from my understanding it's not used nearly as much, but it used to be given to women who were going into early labor, and this was given in an attempt to prevent the onset of early labor. The issue with that, though, is you had to watch that patient very closely, so it would stop the contractions of the uterus because it inhibits muscle contractions, but you had to watch that patient very carefully that it didn't also inhibit heart contractions and lead them to bradycardia. So your book mentions that too as you go through that content. All right, hypermagnesemia. This one's pretty rare. It's usually seen more in renal failures, problems with the kidneys. Again, so you're not losing it in the kidneys, so you have retention of it, and acid laxative abuse, which again is the same as what you would find with high levels of calcium. So again, magnesium sulfate used to treat toxemia in pregnancy and inhibit premature labor. So not only does it have effects on the heart, but it can actually, if it's not watched carefully, you can go into hypermagnesemia as well. And again, that's not table 8.7, it's table 8.8. I apologize about that. And that ends this section.